Today on OsteoBites, we're talking with Dr. Lara Davis about new osteosarcoma clinical trials. So welcome to OsteoBites, everybody. Such an exciting day. My name is Anne Graham, and I'm an osteo warrior and executive director of MIB Agents. It's another gorgeous day, as we've been discussing, which deserves a gorgeous snack. So I brought M&Ms, peanut, obviously, because, you know, not an animal. I hope you have something nice to eat too, so you can settle in and listen to Dr. Lara Davis, who's talking with us about new clinical trials. What could be better? Come back to that in a second, but first I have to tell you about Outrunning Osteosarcoma. We have a lot of vaccinated teams who are getting together in real life to outrun, outwalk, outpedal osteosarcoma. You can participate anytime from now through August 31st. You can do a 5K, a half marathon, a full marathon, or combination. Treadmills, Pelotons, those count too. We're super grateful for the sponsorship of BTG Specialty Pharmaceuticals. You can join or create a team at mibagents.org/outrunning. Also, you get some serious swag, you know, like we do at MIB, super soft shirt, that's awesome, and a couple of other bits of swag that I'm not going to spoil the surprise on. Must have style thing of the season, clearly. So all the links for that will be shared post. But I think let's get started with introducing Dr. Davis. Dr. Lara Davis graduated from Wellesley College and then went on to receive her medical degree from Oregon Health Sciences University. After training in a dual internal medicine and pediatrics residency program at Harvard, she returned to Portland to complete a combined adult and pediatric oncology fellowship with a focus on adolescents and young adults. Dr. Davis joined the faculty at OHSU in 2013, where she's a member of the Knight Cancer Institute with dual appointments in the Division of Medical Oncology and Pediatric Hematology Oncology. She focuses exclusively on sarcoma in both the clinic and in the laboratory. So great, amazing, Dr. Davis. Now that I've fully introduced you, can you introduce yourself too, please?
Thank you, Anne. I think you covered everything. I'm Lara Davis, and I'm really excited to be here.
Yeah, hi everyone. I'm Annika. I'm a junior board member. I'm an osteo sibling, and I'm just excited to hear about these clinical trials and everything.
Hi everyone, I'm Valerie. I'm also a junior board member with Annika, and I'm a rising senior at UNC Chapel Hill. And yeah, I'm really excited to hear from Dr. Davis and all the discoveries. I'm also an osteo sibling as well.
I'm in charge of the slides today, so begging forgiveness in advance, everyone.
I want to, of course, keep this casual, but I did bring some slides because that's what we do these days. We always have slides. So I'm, in full disclosure, I'm going to be just talking about 2 clinical trials that are open. However, I'm happy to answer questions about other trials if there's things that people are curious about. But since we have a short period of time and there are 2 osteosarcoma specific trials that I'm very much involved with that are currently enrolling, I thought I would focus on those 2. The 2 trials that I'll be talking about are first a pilot study that's looking at an enzyme called Glucarbidase to see if we can help adults with osteosarcoma actually successfully receive methotrexate, because sometimes that's a challenge. And then also I'll be talking about a phase 2 study that just opened like last week, looking at nivolumab combined with regorafenib for patients with metastatic osteosarcoma. So we'll start out with the first one. So this is the full title is an open label, meaning there's no placebo. It's not randomized. It's a multi-institutional pilot, so fairly small, looking at the use of glucarbidase in adult patients with osteosarcoma who are getting high dose methotrexate. So glucarbidase is an enzyme, and it basically cleaves methotrexate, which I abbreviate as MTX, into metabolites that are inactive. It's an FDA-approved drug, so the safety and efficacy have been established, but it's only approved for patients that are having severe toxicity from methotrexate at this point. So the why is what I've got on the next slide. So this is an example, just made up numbers, but example numbers of kind of the typical younger person, probably like 15 or less, versus the typical adult, 20 or older, and what happens with their methotrexate when they get methotrexate for osteosarcoma. So I'm sure many of you all have at least some degree of experience with waiting for methotrexate levels to come back, and that long wait. So you get this big dose over, usually it's given over 4 hours, and then your levels of methotrexate in your blood are super, super, super high. And then they rapidly fall. So if you look at that axis on this graph, we're going from 1,000 to 10 in one day. So rapidly fall. But then it starts taking forever, because that 0.1 level is that magic number that everybody's waiting for to be able to leave the hospital, because that's the safe, not toxic levels once it's below 0.1. And usually younger people, kids, will clear that methotrexate between day 3 and 4 after their dose. Sometimes it takes longer, but that's fairly typical. On the other hand, for the typical adult, it takes many, many days, usually on the order of 6 to 7 days. And so it's really pretty difficult to predict who and how this is going to affect. So I've definitely had some adult patients where they clear their methotrexate just fine. They're getting discharged on day 4 or 5 without a problem. But then I've also had adult patients who are in for 14 days, and that can be pretty tough on the mental health, if not the physical as well. So next slide. So what we decided to try is to use this medicine that we know is extremely effective in cleaving methotrexate and giving it at hour 24. So when your body is just naturally clearing from that 1,000 level down to that 10 level, any age is clearing that pretty well. But then after you get that peak exposure that we think is the most important for treating the osteosarcoma, we want to get rid of the methotrexate, try to avoid the toxicity, and so we're giving that glucarbidase medicine. We're giving it at hour 24 and then also again at hour 48 to try to get that methotrexate level down below 0.1 and to stay below 0.1 so that folks can get discharged closer to the 3 to 4 day rather than the 5, 6, 7, 8 day. So this is a trial for adults, as I mentioned. So this is age greater than 25. I did initially ask to have this trial be available to younger people, and the FDA said no, because there is a theoretical concern that giving the glucarbidase gets rid of the methotrexate in the body, and maybe that tail is having some impact on the effectiveness and is working on killing the osteosarcoma cells. Amazingly, although methotrexate's been used for decades, we don't have a great understanding of how it works in osteosarcoma. It seems that the peak is really the important part for the efficacy, and that tail where it's sticking around for days and days is more responsible for toxicity. Now that's different for solid tumors like osteosarcoma versus liquid tumors like leukemia, where you actually want to have a long tail with the methotrexate. So it's different. So the bottom line is that the FDA ultimately said, okay, as long as you don't treat anybody with this under the age 25. because under the age of 25 is thought that they can just get their methotrexate as the younger kids would. And I know that the previously treated with methotrexate it's an important part of this study, and so you can't have received methotrexate before. Ideally, we will be able to treat people who we knew had slow clearance, and they could come on the trial and then get glucarbidase. But unfortunately, because of the way it's designed and kind of the goals of the study for this part, it has to be people who have never gotten methotrexate before. So this trial is open at 5 different sites across the country, trying to make sure that people have access to it. So if you hear of any newly diagnosed folks who have not gotten any methotrexate yet, then this might be an option for them. And if anybody's got any questions, I'm happy to answer them. I was going to go on to the next trial if not.
Yeah, quick question and a comment. One, thank you, Dr. Davis, for recognizing the mental health impact of staying in the hospital beyond a certain point. Your mental health really starts to crash when you're in longer than you should be. It's like a finish line has been moved after you've run a marathon. It's really a bummer. So thanks for recognizing that. And then my second thing is glucarbidase is available still for AYAs who are experiencing toxicity to further rescue apart from the trial, correct?
Oh yes, yes. So if somebody is having like kidney damage from high methotrexate levels, then yes, glucarbidase is the treatment for that to prevent severe damage. But it's actually a obscenely expensive medication, and so it is really only used in absolute toxicity. So not in the scenario where it's taking a long time to clear, your kidneys are a little bit unhappy. We don't use it in that scenario. We use it when it's really essential.
Yeah. Do most hospitals have it on hand?
Hospitals that give high-dose methotrexate should have it on hand.
Yeah.
Because it's always a potential risk.
Okay, thank you.
Any other questions or comments before I move on to this next trial? All right. So Sarc 38 is a study that we are just opening. Really excited about this. It's through the Sarc consortium. Hopefully most everybody's heard of Sarc, which puts on lots of different kinds of sarcoma trials and supports sarcoma research. It's a consortium of a bunch of academic centers and investigators, researchers who are interested in sarcoma. So Sarc 38 is a phase 2 trial. It's combining regorafenib with nivolumab for patients with refractory or recurrent osteosarcoma. And so this is immunotherapy plus targeted therapy. And so the why I've got on the next couple of slides. So I probably don't have to tell this audience that the big why is that metastatic osteosarcoma is bad and we need better treatments, right? Targeted therapy is exciting because for the first time we actually have drugs that are prolonging time to disease progression. There was 20 plus years where we did trial after trial after trial and none of our medicines were helping. Now, regorafenib is one of the targeted therapies that have been recently published. Cabozantinib is another one, sorafenib, pazopanib. There's all some degree of evidence that they help slow down metastatic osteosarcoma from progressing. This graph on the side shows that, right? So this was a placebo-controlled trial because we did not have anything to compare it to. that we knew was effective. So I'll get to that, Kristen, in just a second. So regorafenib targets different kinds of growth factors, and it helps, but it's certainly not enough, right? I mean, slowing it down from a few weeks to a couple of months, 3-4 months to progression is great. It's forward progress, but it's certainly not enough. So then, next slide. Immunotherapy, maybe it helps some patients, probably not much, but there is a little bit of evidence that immunotherapy like nivolumab might be helpful in some scenarios. So the trial, on the next slide, is really thinking about how and why immunotherapy hasn't really worked very much or very well so far. And it's probably because there's a lack of active immune cells within osteosarcoma tumors. So the cells aren't getting into the tumor, and if they are there, they're what we call exhausted. So they're not recognizing the tumor as foreign, they're not attacking the tumor. And then next, the growth factor that we think is particularly important here is in osteosarcoma is called VEGF, vascular endothelial growth factor. And interestingly, that growth factor, it's released by some of the immune cells that are around cancer, and it's also released by cancer cells, and it actually inhibits other kinds of immune cells coming in. It makes the immune cells there kind of become exhausted. And then the next point is that regorafenib targets the receptor of VEGF. So we could reduce the effect of VEGF within the tumor, improve the blood supply, the way that the vessels are growing in a tumor, so that it's not so abnormal, and so that normal immune cells can get in a little bit better, and so that they're not getting shut off or exhausted as soon as they arrive. So that's really the rationale between the two, combining the two. It's not, oh, hey, regorafenib sort of helps, nivolumab might help too, let's put 1 and 1 together. It's really hoping that 1 + 1 = 3 for a scientific rationale, which is why I'm so excited about this. Next one. So here's the key eligibility. Anybody that can swallow pills is potentially eligible. We are making a very concerted effort to make sure that at least half of the patients on this trial are pediatric, under the age of 21. And this is for recurrent or refractory disease, so not instead of our standard chemotherapies that we know work for localized disease. Now, like many clinical trials, we are requiring at least 1 site of measurable disease. So that can be a little bit tricky sometimes. So this is not for somebody who went to have their lung surgery and had all the spots of osteosarcoma cut out and they have nothing on CT scan. There are some trials in that scenario, but this particular one requires that we have at least something on the scans that we can measure so that we can know if we're having an effect. And then, of course, nobody, you can't have already received something like pembrolizumab or nivolumab or regorafenib, pazopanib, sorafenib. Those would be exclusionary. I thought it was also important to note that we are doing a lot of correlative research, so translational research on this trial. We are trying to really make sure that we learn from every single patient involved in this trial so that we can make faster progress. So there's a lot of blood draws, not extra blood draws, but extra blood tubes at each blood draw. And we're even collecting poop So we're going to be looking at the bacteria that are in patients' stool, because there's evidence in other diseases that can predict a response to immunotherapy. And we are asking for biopsies on treatment. So after the first 3 weeks of treatment, adult patients over the age of 18, we will be trying to obtain a biopsy, as long as it's safe and reasonable to obtain. And the reason for that is that we will be having archival tissue, so a prior biopsy or surgery specimen, and then we'll be able to compare what happens actually in the tumor with the addition of these two medicines. So are we getting more immune cells in there? Are those immune cells the kind that we want in there? And that may help us in the future predict which patients are going to respond, predict which patients are not going to respond, and figure out what sorts of other things we might add in or try differently to make it work better. And this is, well, that's funny, we've got little 9s instead of apostrophes. You must be on a Mac, Anne. So this is opening across the country. It just opened in Oregon this past week, and it will be opening at CHLA hopefully within the next month. And then we'll be getting it open at these other sites as soon as we can. But for right now, we're trying to get the first 2 sites up and running as quickly as we can. I'm running this clinical trial along with Dr. Fariba Naveed at CHLA. She's co-PI, and so our 2 sites are opening first, because we're kind of really excited and pushing for it fast. And that's all I have for kind of prepared slides. So I wanted to make sure I can open it up to y'all.
I have one question. It's, if you don't have measurable disease, can this protocol be shared with our oncologist to try off study?
So generally, so part of this study is to check on the safety of the combination. So this, we need to know that this is a not only an effective regimen, but that it's also safe. So I would not recommend using this treatment off of a clinical trial at this point.
Another question we had is from from Sabine. Sorry, I'm mispronouncing nothing. Shicks, and they asked, do the patients participating need to have a high enough expression level of LL1, or this combined immunotherapy / TKI trial not considered dependent on that? And her second question is, what is the hope here? Longer time before progression or a cure?
Right. So of course, our hope is always cure, right? That's always what we're hoping for. And importantly, on this trial, we do have, it's allowed to go to surgery if somebody gets, has a response and is able to have all their spots of disease cut out. They could have it cut out and then continue on study. So our kind of scientific endpoint for the trial is improving over what happened with regorafenib, right? So we know that regorafenib by itself has a progression-free survival of about 3.5 months. So we're hoping that we're going to move that bar significantly forward. We put a pretty high bar to see if this is gonna work or not. And then I think the first part of your question was probably about PD-L1 expression. And you may be familiar with the fact that our current understanding of who responds to immunotherapy in general is not great. So PD-L1 is one of the potential markers. Tumor mutational burden and is another. There's a variety of different things that we kind of think help predict predict response to immunotherapy, but they're not perfect or thorough enough. For this trial, there is no requirement for a particular PD-L1 expression.
I have another question from Heidi Tanner. Do you know of similar clinical trials that allow patients to participate who have taken regorafenib or cabozantinib previously?
So no, I'm not aware of any, and I would suspect that probably the trials would all have similar kind of exclusion criteria, because if someone's tumor has already been exposed to that drug, we expect that there's some reason that the progression happened through that drug, some degree of resistance, and so we think that tumor is less likely to respond.
Another attendee asks, does the targeted therapy and immunotherapy have a big impact on one's liver and kidney?
So that's part of the safety that we're watching. Yeah, so there is some concern that there could be liver toxicity, I think, is one of the biggest organs of concern. If you're familiar with immunotherapy at all, we're all excited about immunotherapy, patients and providers alike, right? It doesn't cause your hair to fall out. It doesn't cause nausea. It doesn't make your immune system go into the tank, but it does have some very real side effects. So patients can have very serious and even life-threatening side effects that can include inflammation of the lungs, or inflammation of the liver or heart or colon, intestines. So these autoimmune side effects are not common, but they're not rare. So combining it with a pill that definitely can have significant diarrhea, significant impacts on the liver, we need to make sure that we're monitoring and making sure it's safe.
Okay, I have two questions here. I'm going to ask them one at a time. Why is regorafenib the TKI of choice here? They say that their son is on pazopanib, and so it seems many others are also.
Yeah, so the regorafenib trial data came out fairly recently, and it's now in the international guidelines as a recommended treatment because it was in a placebo-controlled trial. So there's no question about whether or not it's better than placebo. And there is you can think rationally that all these related drugs probably have similar effects, but we don't quite have the strong data that we do for regorafenib. So in general, many people and providers are using regorafenib instead of pazopanib now. It's a little bit more potent. It has slightly different targets. So it also has similar side effects. Neither drug is anybody's favorite, I would say.
Okay, and then she follows up with the question, when do you expect to have the first results?
I know. So these things never move as fast as we want, right? We expect that the enrollment for the trial will probably be completed within a year, and that's for the first part. So we're enrolling 20 patients to start with, and if we're seeing that it's really working well, we're going to double the size. So we will actually have some information pretty quickly, and you all will know that if we close it down for a period of time after 20 patients and then reopen it, that we're seeing something exciting. If you see us close it down and not reopen it, means that it probably didn't work as well as we'd hoped. And we promise to publish as soon as possible.
Another question just popped up. Someone asked, can immunotherapy damage healthy red blood and white blood cells?
That's pretty uncommon, actually. So it's different than chemotherapy, which definitely does, right? It causes people to be anemic and your platelets go down and your white blood cells go down. Immunotherapy doesn't attack the bone marrow very often. I think it probably rarely could do that, but it would be more of a very rare side effect. It can, as I mentioned, attack other parts of the body though, as an autoimmune impact.
What other pediatric trials do you like?
Well, let's pull up clinicaltrials.gov and see what's brewing right now. I know how much everybody loves clinicaltrials.gov.
Well, let me tell you, Dr. Davis, there's a better
I know.
way.
I know.
There's a better way. If you go to mipagents.org, we have a clinical trial search for osteosarcoma, and you can find a clinical trial in under 60 seconds. It is such a gift. I'm telling you, if you've ever been on clinicaltrials.gov, you know the story. And this is a really fast and easy way to find a clinical trial that's possibly a match to investigate further.
Yes, absolutely. I would, I think that there are, okay, good. I wanted to check and see if this particular one at, certainly that the Osteosarcoma Institute has supported a Dana-Farber trial that I'm very interested in. I think the rationale makes a lot of sense. So that's the olaparib and ceralasertib trial. So again, two very smart, rational study. So I like that one. I'm also very interested in, gosh, I can't remember if it's Dr. Livingston's trial at MD Anderson with hydroxychloroquine. I think that's very interesting. So those are probably the ones that jump to mind as kind of the ones that I'm most interested in today and at this particular time point. The ones that that make sense, I guess, scientifically.
Yeah.
But there's certainly a lot out there. I'm also excited about the GD2 antibody trials. I just haven't. I don't know quite as much about them, and so I think I'm excited, but also I want to learn more.
Right. By the way, on the trial that Katie Janeway's PI on at Dana-Farber, you can go back before the trial opened. She did an OsteoBites with us, and you can get all the information you need on, if you go to our website, you can pull up that OsteoBites, or go on YouTube and you can pull it up. Really great to have, kind of 45 minutes of the PI talking about the trial. Just like, now we have yours, Dr. Davis is going to be the lead. It's really helpful when you don't know what you don't know, and you can go and just get the information directly in what I call the dark night of the soul, when you're like, what do I do next? And you can spend time, looking through the archives and find something that is possibly a match.
Since you specialize in osteosarcoma, would you recommend a osteosarcoma patient jump on a clinical trial for osteosarcoma only rather than immunotherapy only?
Oh, okay, so I think that's a question of kind of going to more of a general trial that's lots of different diseases, but uses immunotherapy versus a trial that's specific for osteosarcoma. And so, gosh, it's my gut instinct is always that if you if there's a trial that's specific for your disease, it probably makes more sense. However, I'm sure that there are exceptions to that. So if your particular disease has a certain marker on it and it has a very high expression of that marker, and there's a new drug that targets that marker really well, but it's an open study to lots of different diseases, then that's a trial that probably makes sense for you. So I think it's hard to kind of give a total blanket answer to that, but in general, disease-specific trials tend to be more make more sense for an individual with osteosarcoma, but that's not 100%.
Maybe you answered this before, and I apologize if this was answered, but what was regorafenib for prior? And how did this come about?
It's approved for colon cancer. Is its primary. It's also approved for hepatocellular carcinoma, but it initially came out probably because people were trying pazopanib and sorafenib. We've known for a long time that these growth factors are important for osteosarcoma growth. And then we started having some of these drugs that were approved for other kinds of cancers, and then pazopanib was approved for soft tissue sarcomas, and so people started using them and publishing series of patients that had been treated with them, and so that we knew there's a little bit of rationale, a little bit of signal, and then regorafenib is a little bit more potent than some of the others, and so that was why it was chosen. And I think there was kind of a lot of interest all at the same time, so several different groups with similar drugs like cabozantinib all started trying it at the same time.
Okay, this is a wild question, kind of shot in the dark, but since it's for hepatoblastoma, does
hepatocellular carcinoma?
Okay, sorry, because I had a question about the liver, and because what do you do when you have a liver, like you have some liver toxicity, and like what's the typical thing, or what's an off, it's kind of an off thing that you can do to help a liver along? I know we have a couple of patients with that, with that problem right now, and they are pausing treatment because of it.
Well, so there's the little bit of liver toxicity, and then there's really bad liver injury, right? And so, for example, with methotrexate, every time you give methotrexate, your liver is going to be unhappy, and that is expected, and that is normal. And what that means is AST and ALT numbers are a little bit high, maybe even significantly high in the 200-300 level, but they're not in the 3,000 level, and bilirubin is normal. When that bilirubin starts going up is when you're really talking about injury, and that's when you got to be more cautious.
Right.
So in the mild toxicity range, we're just kind of holding chemotherapy or reducing chemotherapy potentially, but if we're talking about injury, you got to stop.
Okay. I mean, I've always thought of it as a regenerative kind of organ, like it can kind of bounce back. So hopefully if you're pausing, it sort of heals thyself. That's the liver does.
Absolutely,
right?
Absolutely.
So
I mean, just because your AST and ALT go up with methotrexate, we don't stop methotrexate. You think it gets better, and okay, but
just wanted to say quickly, going back to Sarc as an organization, brilliant organization, you guys. It's Sarc, SARC trials.org. MIB is a member organization, and they're also on our website. If you go to our website under resources, you'll see Sarc on there. It's our go-to place when we're looking for a sarcoma center, for example, or sarcoma specific information. Such good information, such a reliable and trustworthy resource, and really appreciate them supporting this trial and sarcoma and osteosarcoma in general. Really, really brilliant organization.
Yeah, absolutely. And I also appreciate their kind of list and map of sarcoma centers that
Huge.
I find
It's
that
the
helpful.
best one. It's totally, it's the best sarcoma center. Find a sarcoma center destination. Annika, do you want to go with burning questions?
Yeah, so we have like a couple like funner questions just about you. So the first one is, what other profession would you have liked to attempt, or like what that you would like to attempt?
So it could be anything from veterinarian to architect to marine biologist. It sounds like I'm in 4th grade because I'm pretty sure those are all the things that I wanted to be when I was in 4th grade. But I'm still on it.
Fair. I'd still go for those ones too. Those are good ones.
Right?
Yes.
My best friend growing up is a veterinarian, and you know, every once in a while I'm like, that could have been fun. I love my job, but
yeah. Okay, Valerie, what do you have?
Yeah, so another question we had for you is just like, well, what made you want to become a doctor and a researcher? Like, how did you get into pediatric oncology to begin with? Why this field?
I've trained in pediatric oncology, but also in adult oncology. And so I actually only see adults with sarcoma at this point in my clinic. I do some consultations for pediatrics, but on a day-to-day basis, I don't see kids in the clinic. But my research is osteosarcoma. So I think the question, because your audio was breaking up a little bit for me, so I think your question was like, how did I get into this? Yeah. Okay. So when I was in medical school, I knew that I wanted to go into oncology, but I wasn't sure if I wanted to go into adult oncology or pediatric oncology. And I ended up doing a combined residency and then a combined fellowship as well, because I got more and more interested in adolescents and young adults. And then as I got interested in adolescents and young adults, I got more interested in sarcoma, because about 50% of sarcomas happen in adolescents and young adults. So that's kind of the path that got me into the sarcoma realm. And then as I learned more and more about sarcoma, you know, I found the challenges very interesting. So there's 100 different kinds of sarcoma. So I see a new kind of sarcoma that I haven't actually seen before still after practicing for quite a few years on a, not infrequent basis. And I also am seeing a lot of progress. So I think like melanoma 10 years ago was, something absolutely horrible. And now we've got immunotherapy, and, it's made a huge difference for melanoma patients. I see that coming for sarcoma not too long from now. And I'm excited to be part of that.
We need it.
Okay, just the last question here. Would you rather repeat high school or medical school?
Oh. I would rather repeat medical school. High school is just awful.
Oh my gosh, everybody says that. It's so funny. Okay, so we'll wrap up, but I have a few things to talk about. First, wanted to say that really appreciate your work, Dr. Davis. More information on this trial can be found on this video in the comments. It'll be on YouTube, it'll be on a podcast, it'll be on our website. if you registered for OsteoBites today, then you'll be emailed the links that are relevant to this podcast and webinar directly. And really importantly, outbidding osteosarcoma ends on Saturday. So you've got to get in on this. We have some celebrity auction items that are brilliant, including San Diego Padres pitcher Joe Musgrove, who is arguably the top pitcher in Major League Baseball right now. He's brilliant. He will teach you pitching along with his pitching coach, Dominic Johnson. You'll receive a custom special edition 44 Pro baseball glove. It's like a $400 or $500 baseball glove. It's the pro baseball player glove. You'll enjoy a meal together and have an experience of a lifetime for sure. Other experiences on offer are hanging out with the band Good Charlotte right there, including Joel and Benji Madden in their LA studio. So cool. I mean, I feel cooler just even talking about them. Another item is Nicole Ritchie, who will make you better with a personalized styling session with her and her professional stylist from House of Harlow. I mean, so cool, you guys. Like so excited and so grateful for these celebrities caring about osteosarcoma. Like this is a big deal. Also great travel items from 5-star hotels. We have classes, we have art, like my friend back here, the walrus, dancing walrus, he's an Inuit carved walrus, and I kind of hope he doesn't get bid on because I've fallen in love with him, and Miranda Thomas salmon, I mean, just beautiful stuff. Okay, so bidding is on for all the auction items. Go to mibagents.org/outbidding. And next week, we are going to be talking with Dr. Richard Gorelick on antibody drug conjugates. Dr. Gorelick is the division head, Department of Pediatrics at the University of Texas, MD Anderson Cancer Center, and professor, Department of Pediatrics at the University of Texas, MD Anderson Cancer Center. He's also a pediatric cancer survivor and just the finest human being. So we're so excited to have him on next week. Really looking forward to that conversation. So that's it for today. Thanks to our guest, Dr. Lara Davis, for your hard work and dedication to the osteosarcoma community and to sarcoma. Really, you're so brilliant. We're just really grateful to talk to you and hear about these trials. And thanks to our junior board panelists, Annika Vallejo and Valerie Wynn, our brilliant junior board members. Super grateful for you guys today. And thank you for joining us today, and we'll see you next week.